Now we get to the tutorial about the rest of the secondary headaches, and we start out with a headache attributed to a substance. It can be use of a substance, exposure to a substance, or withdrawal from a substance. In this first slide we show a number of substances that by acute exposure can induce a headache, and many of these are important in the research where they are used to experimentally induce headache or migraine that can then be studied by imaging and other means. In practice, they're not terribly important. This is nitric oxide, phosphodiesterase inhibitors, carbon monoxide, alcohol-induced headache, we're not talking about withdrawal, which is the hangover, cocaine-induced headache, histamine-induced headache, and calcitonin gene-related peptide-induced headache. So, very interesting, exciting from an experimental point of view, but usually not so important from a clinical point of view. The opposite is true of the next entity, medication overuse headache. This is an extremely important headache. It's the most common iatrogenic problem that exists, and generally in most populations affects about 2% of the population. It is exposure to analgesics, triptans, and other acute medications for headache that can make the headache worse. So here's a diagnostic criteria. It's a headache for 15 days a month or more in a patient with a pre-existing headache disorder. And this is important because studies showing that if people don't have a pre-existing headache disorder, they tolerate quite well to have daily analgesics and so on without getting more headache. It's a regular use for at least 3 months. So overuse for 1 month or 1.5 months is not enough in most cases to cause medication overuse headache. And some people can have an overuse for more than 3 months and don't get into medication overuse headache. And maybe they then can get it after they have overused a drug for a year. So it's variable. And it shouldn't be better accounted for by another diagnosis. We can move to the next slide, and here we list the different substances or drugs, actually, is it, that can cause medication overuse headache. Ergotamine is permitted for 9 days a month, not more. Triptans for 9 days a month. Non-opioid analgesics, plain analgesics, is permitted for up to 14 days, while opioids only for 9 days, and most headache experts consider opioids to be totally contraindicated to headache patients, by the way. Combination analgesics only 9 days a month. If there are multiple drugs but not individually overused, it depends on the kind of drug. It's either 9 or 14 days, and most other drugs are 9 days a month. It was debated actually whether we should just have 9 days for any drug, and I tend to think at the present time that might be something for the new committee to consider, to simplify these requirements. The mechanism of medication overuse headache is not fully understood, but one aspect is shown on the next slide here, and that is patients with an overuse are hypersensitive. We see here on the VAS scale, after a standardized pressure with this pressure algometer, the MOH patients report much more pain than the control patients who are at the right-hand side of the panel. And as the MOH patients are treated and time goes by, they gradually revert to normal. So this overuse, no doubt, causes a hypersensitivity in the head. It's not only overuse, but it's also withdrawal from a longer lasting substance use that can cause a headache. Caffeine withdrawal headache is well known. Opioid withdrawal headache. Estrogen withdrawal headache is probably the mechanism behind menstrual migraine, because estrogen levels spontaneously drop before menstruation. And there can also be other substances. Headache attributed to infection is divided into intracranial infection, systemic infection. Here we show the intracranial infection, and it's of course the meningitis and encephalitis, either bacterial or viral, or other. It can be parasitic, and there can also be a localized infection, such as an abscess in the brain. There's nothing special about the headache in these cases, except it goes along with signs of infection. Headache attributed to hypoxia or hypercarbia is quite common. Very common is high altitude headache. So a lot of people get headache when they ascend too fast to high altitude. And headache is a cardinal symptom of the high altitude sickness, which can actually be very dangerous. So in this case, headache serves as the warning symptom that people better get down to a lower level. High altitude can also induce migraine in migraine patients, and there are actually studies showing that even people living permanently at high altitude have a much higher prevalence of migraine with aura than in the people living at sea level. Headache can be attributed to aeroplane travel. Whether that's actually hypoxia is somewhat doubtful. And the same is a question with diving headache, because it's a tight mask and so on. There are other reasons why people can have a diving headache. Sleep apnea headache is probably related to hypoxia, but it's not very common that headache is associated with sleep apnea. Next slide is about headache attributed to arterial hypertension. It's generally believed by GPs and the population that arterial hypertension is a common cause of headache, but it's actually not true. It's only when arterial hypertension is very severe or acute in onset that it causes a headache. So therefore we have here headache attributed to pheochromocytoma, headache attributed to hypertensive crisis, headache attributed to hypertensive encephalopathy, and headache attributed to preeclampsia and eclampsia, or finally headache attributed to autonomic dysreflexia in patients who have spinal cord lesion. The next one is cervicogenic headache. And cervicogenic headache is a much disputed entity. Some people think it's very common. Some people think it doesn't exist. There's in any case a big problem in distinguishing a cervicogenic headache from tension type headache. And if we look at the diagnostic criteria here, it says clinical and or imaging evidence of a disorder or lesion within the cervical spine or soft tissue of the neck. So soft tissue could be muscle, known to be able to cause headache. So clinical evidence of soft tissue abnormality can just be tenderness. And it means that this is impossible to distinguish from tension type headache. But then, of course, helps a little bit with the evidence of causation, which is the usual that it has developed in temporal relation. It's difficult to ascertain, and it proves or worsens in association with the disorder. But more specific is cervical range of motion is reduced, or headache is made significantly worse by provocative maneuvers. And finally, that headache is abolished following diagnostic blockade of a cervical structure or its nerve supply. But again, if it's a tender spot in a muscle and you block it then of course you can also treat tension type headache this way. So here is one of the real big problems that we have left behind us in the ICHD3, how to distinguish cervicogenic headache from tension type headache. And for that matter also to distinguish it from temporomandibular disorder, which has the same problems as cervicogenic headache. Last headache I want to mention in this group is headache attributed to eye disorders. And there is not that much relation between eye disorders and headache. Although an ophthalmologist is probably one of the doctors most frequently consulted by headache patients. And very often they get new glasses and adjustment of vision and so on, but there is no good scientific evidence of a relation between refractory abnormalities and headache. But there is, of course, with acute angle closure glaucoma, because it causes severe eye pain, and this eye pain usually radiates to the head, or very often radiates to the head, so that they have a headache. But they don't have a headache without also having pain in the eye. So it's usually not that difficult to diagnose headache attributed to glaucoma. Well, this was just a small selection of the secondary headaches, and thank you for your attention.